our anchor leg is by Dr. Raj Gandhi you've met already, from from Massachusetts General Hospital in Boston. Raj has been a real thought leader in HIV medicine for quite a while now. He's entering the role of vice chair of the ACTG in the next couple of weeks, and he's also been he led the 2022 guidelines, and assuming there's going to be a 2024 guidelines, rumors are that there will be, and that they may be released sometime in the near future. He's also leading that. So I can't think of anyone really better to give us an update on what's coming down the pike with antiretroviral therapy.
Great. Thank you, Mike. And great. And thank you all for your persistence and resilience and stamina to stay to the last talk, and thank the organizers for inviting me. I really enjoy coming to this conference. So in the next 25 minutes or so, I'm going to talk about some new and investigational drugs. Everything here is really going to be off-label. And I have no financial conflicts. And so we're going to talk about new antiretrovirals, and we're going to talk about how they might be used in the future. And we'll also finish off with some of the new drugs that we can think about for the future for treating HIV. So as a Jedi Master once said, it's impossible to see the future, but we're going to try in the next 25 minutes or so. And what we're going to do in particular is we're going to do this in 3 parts. We're going to talk about why we need new ART, because I think there still is a need for new ART. We're going to talk about those new drugs, and then we're going to reflect back and think how we might use those new drugs in the future. So first, why do we need new ART? We've got a lot of different options today. We've got greater than 30 drugs for treating people. We have high rates of viral suppression, low rates of toxicity. But a couple of things that we've heard about during this meeting are the problems with weight gain. We've heard about drug interactions with the integrase inhibitors and multivalent cations, but other drug interactions. We've heard about the fact that daily oral therapy, although it works for many people, I would say most people, there's an important group of individuals for whom daily oral therapy is just a massive challenge. There are also limited information on safety during pregnancy, and then there's the high cost of the drugs here in the US, especially here in the US. So I'm going to give you 3 examples, okay, and this will kind of anchor our talk in terms of the new drugs. I'm going to give you an example of a 25-year-old woman who's doing well on ART. She's been virologically suppressed on a single pill combination, but when she comes to see you, she's worried about the effects of these drugs over the long term and asks you how can she take fewer drugs and how can she take them even less frequently. Second person, so totally different scenario, a person in his 40s who's got swallowing difficulties, depression. He's had on-again, off-again viral suppression because of intermittent adherence. How many of you have patients like both these? And then the last one, a man with multi-drug resistant HIV, with HIV since the 1990s, but he's been on multiple regimens throughout that decade, and now he has virus resistant to all available classes. How many of you have a patient whose virus is resistant to all classes? Fewer. Okay, so I'm going to go through these when we get to the end in terms of how we might use our new drugs for these 3 kind of individuals. So for the first individual, someone who's doing well on ART, I think what we really need are, she's asking for fewer drugs, she's worried about toxicity, there may be an advantage to reducing dosing frequency, and we'll talk a bit about weekly dosing, monthly dosing, and even every 3 to 6 month dosing. For our second patient, the one who's struggling to take antiretroviral therapy, I think the big things are we need something that we might be able to give less frequently, so reduced dosing frequency where we could administer directly, and we've talked about cabotegravir or rilpivirine, but there's other options we hope in the future. And that may also translate with less visibility and less stigma for that second person who's doing poorly on therapy. And then for the third person, someone who's got multi-drug resistant HIV, here we just need new drugs that have new mechanisms and drugs that don't have cross-resistance to our current drugs. Okay, so what we're going to do now is talk about some of these new drugs. We're going to not go in this exact order, but we're going to talk over the course of the next bit on some entry inhibitors. Some of these are available. So we have ibalizumab, which is an entry inhibitor. We have fostemsavir, which is an oral entry inhibitor. And we'll touch on broadly neutralizing antibodies. So those all inhibit the virus getting into the cell. We'll talk about some new classes of reverse transcriptase inhibitors. There's a NNRTI, a non-nucleoside reverse transcriptase inhibitor, MK-8507 that we're going to talk about. But there's a new mechanism here, and I highlighted this with a star. It's called the nucleoside reverse transcriptase translocation inhibitor, and we're going to talk about a couple of them. We'll mention something called Islatravir, which you may have heard about if you've been coming to these meetings. It's moving forward, and then there's a couple of other NRTTIs. That's this new class of translocation inhibitors. In the integrase inhibitor class, there's a longer-acting cabotegravir that we'll talk about. They called it ultra-long-acting. And then there's a couple of other integrase inhibitors that have just numbers that you can see there in terms of that class. We will not be talking about maturation inhibitors. There was a maturation inhibitor who's got a really long series of letters and names right there. That actually got discontinued in its development just in the last month or so. So no maturation inhibitors today. Capsid inhibitors, we just heard about the big news with lenacapavir and PrEP. We know about lenacapavir for treatment. There's also a prodrug of lenacapavir that we'll mention briefly. Okay, but before we get to that kind of plethora of new drugs, I just want to say one word about simplifying antiretroviral therapy with drugs that we currently have in hand. One is bictegravir, of course, and the other is oral lenacapavir. So this was a study that was presented at CROI and then was updated at the Munich AIDS meeting a few months ago. It's a randomized study. It took people on what they call complicated antiretroviral regimens, complex regimens, and those are people who are on multi-pill regimens or people who had multi-class resistance. And they took those individuals, there was 128 people, and they randomized them to either stay on their complicated regimen or switch to daily bictegravir and lenacapavir given orally, okay? And these were people who were pretty resistant. They didn't have integrase inhibitor resistance because you couldn't have that if you were going to get bictegravir. But NNRTI resistance was half of them, nucleoside resistance was 2/3, PI resistance was 1/3, so they had a lot of resistance. And what you're seeing in the graphic in the kind of the two different bluish colors there is 90+% rates of keeping people suppressed with this oral daily bictegravir lenacapavir. This pill now is going to be, these two pills are now going to be combined into one, and there's a study that's going to be launched to look at this as a single-pill regimen. So there's maybe an option to simplify therapy in the future. So keep your eye on that. The name of this trial is called the Artistry Study. Okay, so now we're going to shift to some truly new drugs, and we'll talk about Islatravir. So Islatravir has been around for a little while. It's a nucleoside reverse transcriptase translocation inhibitor, this new mechanism. Its advantage, at least in vitro, is it's got a high barrier to resistance. So in the test tube, it's really hard to get resistant to it. It's also got a pretty long half-life. You can see it's got a half-life in the order of several days. When they first studied this drug, they used it at a fairly high dose, okay? The dose they used was 60 milligrams monthly for PrEP, and then 20 milligrams weekly, and then for daily therapy, 0.75 milligrams. No need to remember those, but I'm going to show you in a minute that they've gone to a lower dose of Islatravir. The reason why they went to a lower dose is when they gave those higher doses, participants in the studies developed lymphopenia and their CD4 counts went down. And when they looked at it, they spent a lot of time trying to figure this out. It's thought to be that what was happening is the triphosphate of Islatravir was accumulating in lymphocytes and it was causing apoptosis, death of those cells. Didn't seem to be mitochondrial toxicity. So what they did is they retooled, and they basically have gone down to a lower dose of Islatravir, 0.25 milligrams daily. It's being combined with doravirine, which is a kind of a best-in-class NNRTI, and it's being given in 3 phase 3 clinical trials. None of these have fully reported out, but keep your eye in the next period of time on a study in virologically suppressed people. Well, they'll get doravirine with Islatravir, so that's a switch study. There's also a second switch study where they're going to compare switching to doravirine, Islatravir to bictegravir FTC-TAF. And then the third study, and I think this third study really is interesting, is it's going to be giving doravirine, Islatravir versus what many of us use, which is bictegravir FTC-TAF for initial therapy. So those are the 3 trials as a kind of an upcoming future attraction. So far, all we've been talking about is daily therapy. I'm going to now talk a little bit about some weekly regimens. Remember, our patient who's doing well was asking about taking fewer drugs, and part of that might be taking it less often. So let's talk about where we are with potential weekly regimens. So the one that's furthest along is this one right here. This is Islatravir, that same drug we were talking about, that translocation inhibitor. Remember how I mentioned it's got a long half-life, many days, so it's amenable to giving it once a week. And then it turns out lenacapavir, the same lenacapavir that can be given subcutaneously, you can give it orally, and that too has a long half-life, so that also could be given once a week. So the pharmacokinetics support once weekly dosing. The dose they chose of islatravir for this study also is a lower dose than in those earlier studies, 2 milligrams, because that's not thought to hurt the lymphocytes. So what we heard about at CROI and then again at Munich is a phase 2 study, people who are virologically suppressed, and they were switched to either daily bictegravir FTC-TAF, kind of standard 3-drug regimen, or weekly lenacapavir and islatravir. In terms of safety, there was no difference in the lymphocyte count, there was no difference in the CD4 count, and what you're seeing in the graphic there is if you look over to this side, 94% rates of virologic suppression in the group that switched over to bictegravir FTC-TAF, and pretty much the same in the group that got the investigational drug, the weekly islatravir, lenacapavir. So I'm going to pause here for, not an anecdote, but for a single participant. One participant in this study developed acute hepatitis B. They were, of course, in the islatravir doravirine group. Tenofovir is protecting many of our patients from getting hep B. So it's a really good reminder to all of us of the things that we heard about this morning and throughout this meeting is to make sure you immunize your patients and get them hep B immune before you switch them off of tenofovir. And so that's just a reminder of that. There are phase 3 studies planned, and those are the names of those phase 3 studies of this weekly regimen. How many of you think that your patients would like a weekly regimen? I mean, not all of them, but it looks like a fair number. Okay, so we will see where this ends up. Another weekly regimen that's further behind, I would say, is these 2 drugs here, again, that go by numbers. One's an integrase inhibitor, 1720 it's an oral, long-acting integrase inhibitor. A recent meeting, it has a PK that allows for weekly dosing, and it's an antiviral. In people with HIV, there was a greater than 2 log reduction with this particular integrase inhibitor. It's going to be paired, we think, with a second drug, which is a prodrug of lenacapavir, the capsid inhibitor, of course, that we already have FDA approved. And so we'll keep an eye on this one. This would be a weekly combination that might be maybe a competitor to the islatravir, lenacapavir, depending on which one gets there first. The phase 2 studies are going to be done in virologically suppressed people, but this is interesting, okay? This is interesting. They're going to actually do a phase 2 study in people who are not on therapy with weekly antiretroviral, and so that would also be something novel. Okay, so let me switch now to another long-acting drug that's also potentially amenable to weekly dosing. Now we're back to our old class of NNRTIs, the same class as doravirine and efavirenz. So it's an oral drug. It's got a good resistance profile. It works against virus that's resistant to other NNRTIs. Should allow for once weekly dosing because it's got a half-life of about 3 days. Its resistance profile is kind of like doravirine, which is a pretty good resistance profile. And it's an antiviral, of course. It drops down viral load in people with HIV. So this drug was being developed by the same company that develops islatravir. They were going to put them together. And those studies got put on hold because of that, remember that lymphocyte depletion that I mentioned before with the high-dose islatravir? So we'll see. I think there's talk about pairing it with a different NRTTI, and so another thing to keep your eye on. And now I'm going to switch from weekly. We heard a lot about PrEP just now, right? So all the PrEP we've been hearing about is either daily, on-demand, or injections. So what about a monthly oral option? So this is a drug that's further behind. This is an oral translocation inhibitor, so same class as islatravir, but it's got a long half-life, doesn't seem to have drug interactions. but its half-life is even longer than Islatravir. That was the one being given weekly. This one seems to be amenable to be given once a month. They've done a single-dose study in people with HIV, and it has antiviral activity. They've done a multi-dose study in people without HIV, without any side effects or any serious side effects. And so there's a phase 2 trial enrolling right now to look at monthly oral PrEP, so 12 times a year. So, okay. So we're just kind of upping the ante here. Now we're going to go to every 3 to 6 month regimens, and then we're going to try to pull all this together and see how we might use these drugs. So 3 to 6 month regimens. So we heard about cabotegravir for PrEP. We know about cabotegravir rilpivirine every 2 months for treatment. There's also a cabotegravir formulation called cabotegravir ultra-long-acting. It's a different formulation. It's not the same cabotegravir that we use now. It's a different formulation. And they're studying it, comparing it to the current formulation, which is the 200 milligram per mil. That's what we have today. They compared the levels compared to this new formulation, which is 400 milligrams per mil. And they found a lower maximum dose, but a flatter curve. And when they kind of simulated this out, they think, the people who make this think that this could be dosed every 4 months. We don't know that yet. It's moving into a phase 1 study, but something to keep your eye on. It would be an every 4 month option. Here's another drug. This one, big series of numbers. I'm going to call it 184. It's an integrase inhibitor. But what's interesting about this integrase inhibitor is that second bullet. Okay, if you look at that second bullet, it's active in vitro against HIV that's resistant to drugs like dolutegravir. So thus far, we don't have a big dolutegravir resistance problem, at least in the US, but there are parts of the world where they are beginning to see some dolutegravir resistance. So this will be interesting if it really gets borne out, if it's active against dolutegravir-resistant HIV. And when they look at the drug levels, because they've studied it in people without HIV, the drug levels of this drug, 184 we'll call it, are anticipated to be active against drug-resistant HIV. So if we need a kind of a rescue for dolutegravir resistance, if this is borne out, this might be it. There's a phase 1 study of injectable 184 in people without HIV. And when I looked at clinicaltrials.gov last night, there's a phase 2 study that's actually completed in people, in adults with HIV. So no results were available, but something that might be coming maybe at our next big meeting. This will be even briefer. These are other drugs that are being developed for every 3 months injections. I won't go into these in detail because they're really very early on. What I will go into some detail on is something that you've all been hearing about for a few years now, which are these broadly neutralizing antibodies. So I want to take a step back and just say, why are people interested in broadly neutralizing antibodies? It turned out about 10 years ago, people in the immunology field got really good at finding B cells that make antibodies, isolating them, and then cloning them so that you could make clinical-grade products of antibodies. And that's what led to this kind of real ferment in the field of broadly neutralizing antibodies. So I suspect you either have seen this before or saw this at the meeting, but what is the big deal about broadly neutralizing antibodies? So first, what they do is they bind the HIV envelope, and they prevent the virus from entering cells and thereby inhibit HIV replication. You could think of them as a really fancy entry inhibitor. That mechanism of inhibition, though, is different than all our other drugs, and therefore, if you've got virus that's resistant to our current drugs, they will be sensitive, we think, to the broadly neutralizing antibodies. One other interesting thing, the BNAbs target human proteins. They're not targeting the virus. They're targeting reverse. They're targeting the virus, not targeting human proteins. Many of our drugs are targeting or having an effects on human proteins. And by targeting HIV, these are thought to be safe. And so we're evaluating them for prevention, but also for treatment and also for cure. So the two big sides of the envelope, the viral envelope, one is called the CD4 binding site, that's where the viral envelope kind of locks in to the CD4 receptor, and the other is something called the stem, and those are the two sides of the envelope that the BNAbs that we're going to talk about now are pointed at. So the one that I want to push up first is because this is a study that's going to open as a phase 2 study. It's a study of lenacapavir, that same capsid inhibitor, but with two different bNAbs. One is called teripavilimab, one is called ziloverlimab. They're antibodies that are long-acting, and we're going to talk about why you can do this with bNAbs, but they last for 6 months. Turns out in people in the US, most of our patients have clade B HIV. About half of those people have virus that's susceptible to both antibodies, and 90% of people in the US have virus that's susceptible to one of those two antibodies. So the first study of this was 20 people with HIV. Their virus was susceptible to both antibodies. They got lenacapavir, which lasts 6 months, subcutaneous. They got a single IV dose of the antibodies, and they stayed suppressed. 18 of 20 people stayed suppressed for 6 months after that kind of injection. There was another study that was presented this year, 10 people whose virus, this time only susceptible to one of the two antibodies, and 8 of those 10 people who got the same kind of regimen stayed suppressed for 6 months. So a study that's going on right now is in adults, with people with HIV, who have virus that's susceptible to both antibodies, and they're either going to get lenacapavir with the antibodies or stay on their ART, and then they'll cross over. The people who stayed on their regular ART will switch over, and we'll see, is this going to lead to a viable option for every 6-month therapy? Don't know yet, but something to keep an eye on. Another antibody, and then I'll kind of sum up the antibody part and move to the last phase, is another antibody called N6LS. It can be given subcutaneously or intravenously, and there's a couple of studies that are starting. This is just showing you that when you give this antibody, the viral load goes down, and there's 2 studies in people, one study in people without HIV as PrEP, and then another study in people with HIV where it's going to be given with the integrase inhibitor cabotegravir. So where to next? Where are we going with these bNAbs before we come back to our patients? There are a couple of advantages to bNAbs, and this is why I think, despite the fact that there's not a single bNAb available today for commercial use, this is why people are still investing time and effort into this. You can engineer these to be very long-lasting. I've already mentioned that some of these are 6 months, but it's possible that you can engineer them to be even longer-lasting. There's even a proof of concept that in humans, not in animals, but in humans, that you can give this with a harmless viral vector where they can last for well over a year. Small studies, but if you could do that, I don't think we'll be a one-and-done shot, but we could be one and done for a year, which is a big advance. And then there's some tantalizing data, still to be determined, that these bNAbs may reduce the HIV reservoir and, interestingly, might spawn some antiviral immunity. Some immunity against the virus, so anti-HIV immunity. I do think that we should continue to study them either on their own, combination bNAbs, or with small molecules like lenacapavir, cabotegravir. There are some people who rebound, though, and so we do need to understand what's going on with that. And then we do need to understand what's going on with the reservoir. The last topic before we come back to kind of how we're going to use these drugs are implants. One implant I don't think is going to have legs. It's a TAF implant. In women without HIV, they ended up having about 1/3 of people who got these implants had to remove it early, and the delivery was lower than expected. And then there's a dolutegravir implant, but so far just in kind of mice studies. But I think there'll be some effort on trying to develop implants, kind of like we have implants for contraceptives. I think the same idea would be pursued for HIV. Okay, so how might we use these new drugs? So long-acting ART we've heard a lot about, and actually when I first gave this talk, this was still at the kind of the dawn of the era of long-acting ART. I think we're firmly into the era of long-acting ART. I think for most of my patients, they're still, of course, on daily oral therapy, but for people who are struggling to take daily oral therapy, swallowing difficulties, substance use disorder, stigma, depression, I think these people are really benefiting from long-acting ART. I don't think, I didn't put into this slide deck the results of some of the studies of long-acting ART for people with adherence challenges. Mike, do you know, or Laura, have Latitude and some of those studies already been highlighted during this meeting? I didn't prepare slides on those, but these are in people who are struggling with daily oral ART? Okay. So I'll pause here. We won't show a slide on this, but the kind of the studies of long-acting ART in people with adherence challenges fall into two buckets, okay? One was a randomized study done by the ACTG called Latitude. And what it was is in a little over 400 people who were having trouble taking daily oral ART, they started them all on daily oral ART with conditional economic incentives, essentially kind of financial incentives to get suppressed. And then they got randomized to stay on oral ART or switch over to long-acting cabotegravir rilpivirine. And what they found is that there was a better outcome, fewer virologic failures in the people who, after they got suppressed, got put onto long-acting injectables. So that was kind of a proof of principle that for people who are struggling with daily oral ART, that cab rilpivirine may offer a good option. That was given once a month. Then there's a number of demonstration projects in San Francisco. There was a study from Mississippi looking at people who are viremic, who had not gotten suppressed. So this is not on the FDA label. And in those instances, also high rates of success, as long as people were, of course, coming to the clinic and getting the long-acting ART. And so that has opened up some additional options. Mike mentioned the IAS-USA guidelines. And if you want to read about our thoughts on this in February of the year we're in, we put out a kind of an update on the use of long-acting ART for people with adherence challenges, where we essentially said if you have no other good options, the patient's CD4 count is less than 200, where they're really at substantial risk, that's the setting where you should consider this. And happy to take questions if this hasn't already been covered. So, resuming kind of where else we might use this, I think there's also an opportunity to combine long-acting ART with other appointments. Methadone refills, psychiatrist appointments, health centers. So I think there's some novel ways to kind of decentralize how we give long-acting ART. We heard about a few of the considerations with long-acting ART. It does have a long drug level tail. So we need oral bridging if there's missed injections. We need ways to remind people, and we need kind of intensive case management. The logistics, our clinics, of course, these have to be given in clinics right now. There's no self-administered long-acting ART, and so that puts, of course, a burden on clinics. Toxicities, if they develop, some thought about what to do if a person becomes pregnant. Now, thankfully, the current drugs, cabotegravir, there's a growing safety profile with cabotegravir in pregnancy, and same as we just heard with lenacapavir. And then what about if a person needs rifampin or some other drug? Not common, but something to be conscious of. And then, of course, the case management for people with adherence challenges. Second scenario, the person with multi-drug resistant HIV. This is the patient I mentioned to you. I won't go through those drugs, but they're all resistant, all in black. So how might we use these new drugs in people with multi-drug resistant HIV? Here, I think, thankfully, we have 3 FDA-approved drugs today that work against multi-drug resistant HIV. We have the IV ibalizumab, not easy to give, but can be a lifesaver. We have the oral fostemsavir, twice a day. Remember, it's twice a day, not once a day. And then we have the subcutaneous lenacapavir. So 3 drugs today. I think Islatravir, the drug I started with, because of its new mechanism, a translocation inhibitor, is likely to be active against drug-resistant HIV. I think the BNABs and some of these newer drugs that I touched on that are early are likely to be active. 2 slides on cost, or maybe one slide on the cost. So these novel agents may not be cost effective if the price is too high. So ibalizumab, when they looked at cost effectiveness, is not cost effective, but this is the important part. For really drug-resistant virus, I think you can justify higher costs than in people who have drug-sensitive virus, because there's a much, much smaller group of people with drug-resistant virus than with drug-sensitive virus. There's a really interesting concept called the role of rescue, which is that it is justifiable to spend more on when someone whose life is in peril. We know that from some of the other diseases we take care of. But I think for new drugs, especially those for initial therapy, they have to be priced low enough to ensure access to people here in the US, but also around the world. By the time we're done with this decade, 2030, it's estimated that almost 5 million people are going to need some kind of second-line therapy in Africa, and a lot of them, not all of them, but will need drugs that work against MDR HIV. So here's my last 2 slides. The first patient that I talked about, the 25-year-old who wants to take fewer medicines, I think where we may have some options for her are some new daily and weekly regimens with fewer drugs, fewer pills, less toxic, more convenient, and hopefully more flexible. So we don't have it today, but I think we're getting there. For the person who's got the intermittent viral suppression, I think these long-acting formulations really can improve adherence, but we need those supportive systems. It's not just about the drugs, it's about the systems that you kind of build around the drugs to facilitate delivery and to ensure follow-up. And then I think for my 55-year-old whose virus is resistant to all available classes, I've shown you a couple of examples where we have some FDA-approved drugs, and I hope others on the way that really would give that person some options. So here's my last slide. Why we need new HIV. I hope I've convinced you that we need to overcome some of the limitations of our current therapies with less toxicity, fewer drugs, less frequent dosing, and activity against those resistant viruses. The drugs that I've talked about, some are in our current classes. We have some integrase inhibitors, we have capsid inhibitors, but there's also some drugs that target novel mechanisms. We've talked about some drugs that go out for 6 months and some potentially innovative delivery systems like implants. And then I think how we're going to use the drugs depends on the person in front of us and their needs, but I think for all people with HIV, we need to redouble our efforts to provide more options, including during pregnancy, reduce costs, and ensure access. I think a lot of this has still got to be about access here and also around the world. So with that, I'm going to stop. I want to thank two people that you probably know, Melanie Thompson and Trip Gulick, who shared slides, and thank you all for inviting me today.
Wonderful. During Raj's talk, I was informed appropriately that buprenorphine injectables are actually sub-Q, so you don't have to worry about turning the other cheek. You can get by with just
that's kind of a
another type of injection. I was a little disappointed because it was a nice, fun thing to say. Okay, question from the floor.
Hi, thank you so much for that presentation. It was great. I'm excited about future options. I have a congenitally infected patient. He's living with cerebral palsy as well, is resistant to everything. We got him on Fostemsavir before it was FDA approved, but unfortunately he's crushing it inappropriately. He's also on ipilimumab and now on lenacapavir. We do have him virally suppressed as it stands. We have some issues maintaining ipilimumab with home health insurance, all those things. And so my question is, out of those future options, what are currently available for requests for compassionate use, and which ones do you know are not oral?
So 2 questions. So a person that has been managed to be suppressed through a cocktail of, I think, ipilimumab, Fostemsavir, and lenacapavir? Yes. And I think since he has cerebral palsy, some of these, it's hard, if not impossible, for him to take oral drugs. Is that right? Yes. So the Fostemsavir you're managing, but with some difficulty.
We're inappropriately crushing it.
Okay.
It's a long-acting agent. It's not supposed to be, but we're doing it anyway.
Got it. It's a good question. In terms of the drugs I talked about, which are available on compassionate use, I would say most of these drugs are still in phase 1 and phase 2, so I don't think, I could be wrong, I haven't checked myself, that they're available for compassionate use. Islatravir is the one that's in phase 3 trials, so I would have to check. Maybe someone in this audience knows if it's available for compassionate use. It is oral, though, so that might be the issue. But it is in phase 3 trials, and that might be the one I would look for first. So,
So speaking of Fostemsavir, what about intrinsic drug resistance to Fostemsavir?
So I learned, because of the guidelines, that apparently there's some classes of HIV. One of the clades that we don't see much in the U.S. might be kind of this clade that's either in Southeast Asia that's intrinsically resistant to Fostemsavir. I would have to look that one up. Right. But I think in large part, Fostemsavir, I haven't seen any clade resistance. It's not in the same class as so Maraviroc, the oldest of the entry inhibitors. That should not confer resistance to Fostemsavir. So you know how we check tropism for Maraviroc? That's not an issue for Fostemsavir because it's an entry inhibitor, but it works differently than the CCR5 inhibitors. It's working on the virus side.
So this is a question that just came in, but I remember people asking the same question around 2000. which is given how safe and effective our meds are now and upcoming patent expirations, are we approaching a time when there will be little or no financial incentives for companies to develop new drugs?
Probably, I'm sure there are people who could speak to that even more than I can. I mean, I think because, today, since we don't have a cure, HIV meds are for life. I hope and think that there'll be continued development of drugs to try to give these type of options that we were talking about today. It is true that some of the bigger drug companies, not all, some of the drug companies that used to make HIV drugs have gotten out of this space, and it's largely because unless you have a drug that's going to be without boosters, I think boosters are a problem. I think it's unlikely that we're going to have a market for drugs that need pharmacologic boosting, for new drugs that would need pharmacologic boosting. And then I think a lot of these companies are looking at these long-acting options, weekly, monthly, et cetera. So it's contracted compared to 10 years ago, but there's still activity. So.
Right, and the dynamic isn't quite as simple as it appears. In other words, drug comes off of patent. The original company continues to make that drug. The generic companies struggle because they have to get up and running, and it takes a year or two. Sometimes the parent drug company will actually buy out the generics rights and continue to make it. And so there's a lot of churn in all this, but there's a lot of incentive for the drug companies to make a brand new product that might have an advantage, a number of which you went over in your talk, because that resets a patent clock and they end up making a good amount of money, especially in the U.S., because they can sell the product at a high cost. And even though ADAP and other things get discounts or rebates is a better way to describe it, they end up being handsomely rewarded for this. So assuming those criteria are met that you described with some of the new properties, I think there'll still be drug development. The last question here is, what is the best way for patients who might be interested in clinical trials to get involved or find out ways to access these trial sites?
That's a great question. So I would say there are several clinical trials networks in the U.S. One is the one that Mike mentioned that I'll be the vice chair of, which is the NIH-funded AIDS Clinical Trials Group. I'm going to briefly say that the ACTG, and then I'll come to some other trials, focuses basically on 5 areas. One is new development of antiretrovirals. So, for example, there's going to be a study coming out in the ACTG in people who are struggling with adherence, who have NNRTI-resistant virus, looking at the combination of cabotegravir with lenacapavir to see if that will work in people who are having trouble taking a daily pill. So the ACTG does those type of studies. It also has we talked about hepatitis B this morning in terms of vaccines. Hepatitis B we can treat in people with HIV, but we can't cure. The people at NIH think that there may, unlike with Hep C, where the companies jumped in, with both feet and both arms and legs, hepatitis B is slower, and so there's probably going to need to be NIH-funded research on hepatitis B cure, and so the ACTG is doing those as well. Comorbidities, Reprieve, the study that we heard about also came out of the ACTG, and now there's studies being designed to look at excess weight gain. And then the last area that's being looked at in the ACTG is cure here in the US. Outside of the US, there's a pretty robust TB agenda in the ACTGs. In fact, that's probably the biggest part is TB, latent TB, active TB. In terms of how do you find out about new clinical trials, one way is clinicaltrials.gov. So many of these studies I showed you today, if you or potentially your patients are interested, that's how I find out about new trials is through clinicaltrials.gov. Those would be two things.
So finding a site, especially an ACTG site that's near you.
There's about 40 in the U.S., so not every place, but about 40 or so.
Right, and then for these brand new drugs, it's a little bit exceptional here, but sometimes there could be something at the NIH Clinical Center in Bethesda, and if you're eligible for those, they actually will pay for the transportation back and forth for patients. It's used a lot for more rare diseases where they're trying to get patients from all over the country, but there might be some new innovative drugs or approaches that the NIH itself, the intramural program, will be sponsoring, and that would be another way.
Two patients I've sent down to NIH, or who went down to NIH. One was a person with really complicated iris, where they ended up using a TNF inhibitor for the iris. So they tried that kind of last ditch. And then another was in a person who had idiopathic CD4 lymphopenia, didn't even have HIV, but had cryptococcal infection. And it was the NIH folks, a person named Dr. Irini Soretti, who helped kind of put together some studies on that.
She's done some innovative work with that.
Yeah.
Okay, well, Raj, thank you very much. And
pleasure.
maybe the other chairs will come up and we'll wrap up.